The question is from a mental health professional, non-medical background, but working with patients who may have chronic diseases, particularly pain. And the concern of this mental health professional is that the manner in which the patients that they see in their mental health context, that their patients are being prescribed medications in a way which may either facilitate or promote inappropriate use. So for example, receiving 200 tablets at a time for an indefinite period of time. And the question from the mental health professional is, what's the appropriate way for that person to proceed in interacting both with their patient, or their client, and the other medical professionals in that client's healthcare team? And I mean, I have to, from my standpoint, I mean, although I am a doctor, there was a time when a couple of weeks ago, I actually listened to advice from somebody who wasn't a physician. It does happen. And I think unless the advice is proposed, it never gets into the system. So it's not helpful to sort of sit in the office with the other non-medical health professionals complaining about those idiot doctors again. You really have to get into the interaction. One of the places where we see it, and this is a real area of communication which has been identified, is the issue of different healthcare professionals communicating. So you have nursing professionals, you have pharmacy professionals, you have counseling professionals from a non-medical background, you have medical professionals of a variety of specialties. And you really cannot achieve good care unless those people talk to each other. People have access to different information. I got great stories from pharmacists. I had pharmacists phone me up about this patient that I thought was on, pretty stable ground. They were very consistent with their medications. They never came early for prescriptions and so on. The pharmacist phoned me up and said, this guy was here last week. It was really odd. He came in and he didn't want to put it through on his disability benefit, so he only took 10 pills, and then an hour later he came back and he picked up the other 30 pills, and he had cash for it. What do you think that was? I said, geez, I don't know, maybe he got a job. But so, I mean, that communication piece, you get access to amazing pieces of information. And so the first thing I would suggest is that information has to be fed back into the system somehow. At the end of the day, if one has a belief that something truly inappropriate is happening, sort of the nuclear option is to complain to the College of Physicians and Surgeons to say, look, especially if it's happening in more than one instance, to say, could you look into this? The CPSO has adopted, so I mean, they have, if they come and suggest that you take a course, one is well advised as a physician to take the course because they do have other leverage they can use, but in fact they have adopted very much an educational approach to managing physician competence. And as I say, that is kind of an aggressive option, but on the other hand, if you actually believe that harm is being done to patients and you have information that would suggest that is not totally inappropriate, particularly if you've already approached the individual physician in question and they've either neglected or rejected or somehow not tried to deal with the problem. I don't know if there are any other comments about that, but it's a really complex and touchy issue because you don't like to get into arguments, but most of us don't, for the most part.
I think as Dr. Buckley said, talk to you're a non-professional, but talk to the professionals on your team. And do they know this? They may not know this. It may not have been brought to their attention. So bring it to their attention and then as a group, figure out what's the best course of action. And if probably at some point you need to talk to the actual person who's getting the prescription and figure out what's the best plan there.
And I just want to echo the communication between the different healthcare providers is key, and especially between physicians and pharmacists. And right now, that's not optimal in our healthcare system at the moment. They're very divided in most cases, and it's difficult to actually communicate directly when you're independent community pharmacists and when you're dealing with different physicians. And the other thing I just wanted to pick up on was just to highlight again the quantity piece, and that's another sort of education piece we're trying to get out, is around reducing the quantities of opioids that are out there. and also to take the message home that whatever quantity of opioids you do have, to make sure it's secure and locked up, because we know from our student surveys that over 70% of kids in school who use prescription opioids non-medically are getting it from home. So whether it's your kids or the friends who are over, or just to make sure that you've stored the medication safely is quite important. And again, trying to reduce physicians prescribing large quantities for like 50 tablets for something that's only going to be needed for a couple of days, that type of thing, just to reduce the actual amount of drug that's actually out there.